Welcome. In this video, we shall look at in my first lecture we looked at diabetes type 1, but for now we shall zero down to diabetes type 2. So diabetes type 2, earlier on we said it is caused by the insensitivity of the cells to insulin produced. So for the epidemiology, it represents about 80 to 90% of cases of diabetes mellitus, while for the type 1, it takes around 10% of the cases. And secondly, it usually occurs in older patients above 40 years and obese individuals. But still it can occur in children, but the main bit of it is that it occurs in older patients. The risk factors for someone to have type 2 diabetes: one is sedimentary lifestyle, poor nutrition, overweight, and obesity. The pathogenesis, it's mainly genetic factors play a more important role in type 2, which we didn't see in our first video for type 1. So here genetics plays a greater role. The clinical presentations: one, there is body weakness, unexplained body weakness. Second, there is weight loss, and thirdly, there is susceptibility to infections. Important points to note is that in diabetes type 1, it is highly associated with DKA, that is diabetic ketoacidosis, while in type 2 diabetes, there is development of hyposmolar non-ketotic coma. But in real sense, in practice, DKA can occur even in type 2, so it can occur both in diabetes type 1 and type 2, while the hyposmotic coma, it is really unusual. For hyperosmolar non-ketotic coma, what are the findings? One, there is marked hyperglycemia. So in diabetes type 2, there is marked hyperglycemia. Secondly, there is more dehydration than DKA we saw in type 1 diabetes. Thirdly, there is low free fatty acid levels, so we don't expect ketone bodies in diabetes type 2. So in the patient's breath, you don't expect sweeter smell due to the ketone bodies, which we saw in type 1. This is a table to compare type 1 and type 2 diabetes, what we have been talking about all along, but here it is well summarized. It gives you a good picture of it. The diagnostic criteria for diabetes mellitus. So what do we base on to diagnose diabetes mellitus? There are about 4 criteria. One, if we perform a single random glucose level and we find the blood glucose levels are above 200 milligrams per deciliter in presence of the symptoms we have seen, that's one. Secondly, if we perform 2 random glucose tolerance tests with a level above 200 milligrams per deciliter, even in absence of symptoms, that is enough to tell us that you have diabetes. Thirdly, if we perform a 2-hour glucose tolerance tests with a level greater than 200 milligrams per deciliter. Then the third is if someone has a fasting glucose level greater than 126. So here you tell a patient to fast overnight, and you take or you measure their blood glucose levels using a glucometer, and if it is greater than 126 milligrams per deciliter, then they have it. So let us go for the complications, pathogenesis of diabetic complications. So there are 4 of them. The first one is activation of the polyol pathway with accumulation of sorbitol, and once sorbitol accumulates mainly in the eyes, we can have cases of retinopathies and blindness, so patients with time may go blind. Secondly, there is production of advanced glycosylation end products, and that can lead to atherosclerosis of the small vessels, and that can predispose someone to have gangrene of the lower extremities. Thirdly, there is increased oxidative damage. Then fourth, there is platelet dysfunction associated with increased aggregation. An important point to note: diabetes mellitus is the #1 cause of end-stage renal disease, blindness, and non-traumatic lower extremity amputation. You should note that it's the #1 cause of end-stage renal disease. So the effect on the pancreas is that diabetes can cause reduction in the number and size of the insulin cells, that is in type 1, while in type 2 there is amyloid deposition in the pancreas. Then effects on the kidney: there is microalbuminuria, that's presence of albumin in the urine, and this increases chances for the condition to progress to diabetic nephropathy. This is a histologic presentation showing amyloidosis deposition in the pancreas. More of the complications: we have seen this diabetic nephropathy, we have seen that we have seen it can cause peripheral neuropathies. There is a sensory loss in patients more than the motor loss, so patients really don't feel pain. They rarely feel pain, and that predisposes them to even more injury. For vessels, we have seen atherosclerosis can occur in large vessels, and that can predispose to formation of infarcts in organs like the heart, the brain, while in the small vessels there is hiding arteriosclerosis that can lead to gangrene formation, which may require amputation. Complications: we have seen all that. In the eyes, we have seen retinopathy, cataracts. Most of this we have talked about it. In the skin and the soft tissue, we have seen diabetics often develop ulcers and gangrene over the legs and require amputations. We have seen that. And in pregnancy, when a mother has diabetes type 2, most of them give birth to babies overweight. I find a baby being born with a weight of over 5 kgs. Why is that? Because the excess glucose in the mother's saturation is capable of crossing the placenta, and in the fetus the excess glucose can be converted into the fats. This is a representation of the diabetic ulcer. And thanks for listening. Abdrazak. Don't forget to subscribe to my channel. Thanks for listening.